Here we are. Welcome to London, guys. Welcome to London.
So let's get to it. So leg ulcers are bad. We all know that. It's a terrible condition. And in this country, I had the privilege of working with the all-party parliamentary group, we identified that around 500,000 patients per year live in the UK with a venous ulcer. That's 1 in 100 people. Over the last 10 years, that's doubled, and that's associated with £2.7 billion per year in the UK. 2.7 billion. And around 10 to 15% of those will have some form of arterial disease, which equates to over 50,000 patients in the UK, which is a lot of work for Lorenzo, it's a lot of work for everybody in the department. Now, we all know about leg ulcers, or we think we know about leg ulcers, and it was interesting to hear Thanos's talk about ignorance. But the truth is, there's lots of information out there. This is a great review by Adam Singer saying about venous, arterial, neuropathic, or pressure ulcers. But the reality is, you see a lot of these patients. This is a patient who's got an arterial-looking ulcer, hemosiderin deposition, trauma, and where does that really fit in? And when we think about all of this information that's out there, really, there's a lot of confusion. So,
let's throw it open to the floor. So let's try and define the problem that we're going to talk about first. You all got your flags. How do you define a venous-looking ulcer? Green flag if you think if it's a venous-looking ulcer with an ABPI of less than 0.7. Yellow flag if you think a mixed ulcer is a venous-looking ulcer, but you have significant arterial disease on imaging. And red flag if you think it's just mixed from how you look at it. Flags up. Okay, so mostly yellow. So most people think it's a venous-looking ulcer with arterial disease proximal to the imaging site. I've got to be honest, that's probably where I come from as well, although PK is probably a bit more, you look at the ABPI as well, right?
Yeah, and I think really this is a great article by Chung Lim, who was one of our fellows a few years back and is now working at the Royal Free. It's about early assessment, and in the hospital, it's very rare that I see the first time a patient who's got an ulcer. They're out in the community, and we need to be pragmatic. How do we pick them up? We need to do an ABPI, and I think an ABPI is very important still, to try and decipher whether there's an arterial component versus a not. And I'd really ask, does anybody use anything other than an ABPI in the community? And that's $1 million question. I don't know what you think about any
the other
of the
question is, in a lot of these patients, like the leg that you put up, it's bloody painful to try and get an ABPI on that leg. How do you deal with that problem?
Good.
Thank you. You can perform toe pressure also.
Yeah, and I think that's...
In the community, that's also the tricky question.
Exactly, and I think...
Or TCPO2 measurement.
But is this something that can be done in the family doctor clinic?
No.
No.
Only in specialty.
Only in a specialist clinic. And I think that's where a big problem, by the time these patients get to us, who's seen them, who's decided who we're not seeing. When they come and see us, we have a rationale to intervene. But there are a lot of patients out there that we're not even getting to see because these basic measurements can't be done in the community.
And I think that's right. And I think the first principle is to make sure you have an early assessment. And if you are worried about an ABPI, to make sure that you have the pathways to get them into your hospital. Obviously, there is wound care, and it's a very important aspect of any wound to have a good team around you. And we're very fortunate to have a team of nursing staff that forms part of our multidisciplinary team, not just for the wound care, but also for compression therapy. And in certain patients, even with a mixed ulcer disease, it's important to recognize that trying to reduce the edema is still very important, but you do need expertise. And we're fortunate to have Azeb, who is our specialist ulcer nurse, and this is on the day that she was in the all-party parliamentary group. And actually, it's really important to get the team around to ensure that you have this effective thing. But ultimately, they come to us in hospital, and what we're going to talk about is a few cases of what to do. And they're pretty controversial, and they're pretty difficult to manage. And really, I want to get some information here, because we are still dealing with many of these today. So, the first one. This is an 80-year-old male who appeared in my clinic. He's got bilateral leg ulcers, he's got severe pain, and all the ulcers have got recurrent infection. So his primary care physician has been prescribing him lots of antibiotics all the time. These are the arterial and a venous duplex. So the arterial duplex shows that he's previously had an SFA stent. He's got a 50% stenosis distal. He's got an ATA occlusion. On the venous side, he's got femoral vein incompetence. He's also got superficial venous incompetence. The question is this.
So, flags again. Would you, in the presence of both superficial venous disease and arterial disease, what order do you do things in? So green flags if you treat the arterial disease first and if you treat the arterial disease first and only treat the venous reflux if they're not getting better. Yellow flag if you would do a staged planned treatment of the venous reflux and then the arterial at a later date. And red flag if you do the venous reflux first and then come to the arterial if the ulcer is not getting better. That's a good question.
What's the ABPI?
Very good question, Paul. So this ABPI was 0.7.
So right in the middle. So
On both sides?
On both sides.
On both sides. So pretty much the whole room believes that you would treat the arterial disease first and only treat the superficial venous reflux if the ulcer is not getting better. Interesting.
I think we have one yellow flag back there.
Yeah, here we are.
Thanks. I would treat the venous disease first because it's simpler to do. I'd give foam sclerotherapy, probably in the clinic, very easy, and see how the patient got on.
He has also a deep venous disease, right? He has also the insufficiency of the superficial femoral vein.
No, superficial vein.
Okay.
There is some incompetence, but not obstructive lesions.
Yeah, even if there's deep venous reflux, I still want to break that pathway to the ulcer.
Yeah, I mean, I think also what Paul said about the ABPI is key. Because, of course, if the ABPI was 0.2, 0.3, 0.4, then probably I would definitely flag the green.
Yes, flags up again, because I think everybody has votes before knowing that it's 0.7, so the green outcomes go less popular when we were able to know that this is 0.7. So
that's because he was listening to the first comment, which is the ABPI is the very important factor to have here.
So shall we do it again?
Yes, let's do it again. ABPI 0.7 in the algorithm. Who would treat the arterial first or the venous first? Raise your flags again.
So green for arterial first.
Still quite a lot of green.
Still a lot of green, but a bit more mixed now.
Okay, so what we did is that we treated the GSV and the SSV first of all. We did endothermal ablation, and unfortunately there was minimal improvement. And so, NT, take over.
So he had multiple angioplasties, actually, of these lesions that were borderline significant in the first place. And we ended up seeing him 3 times over the next 2 years for angioplasty DCB, repeat angioplasty DCB, trying with the goal of keeping this SFA patent, but I'm not sure we actually did anything for the patient because he was still in severe pain. The recurrent infections got better with the wound care, but he was still in a lot of pain. We tried nerve blocks, we tried a lumbar sympathectomy, and even then there's still no improvement, and now we're in a position where we're considering amputation for this patient.
So who would amputate this patient? Red for yes and green for no.
Also, we need to remember that this patient is in excruciating pain. So the patient probably, I think, was begging for an amputation. Am I right?
Well,
could it be?
To be fair, they came down to us from another institution hoping that we could avoid it, but
okay.
They're in a bit of a problem, yeah.
So who would amputate a patient like this? Honestly, come on, guys. There's no like, if you say amputation, I think it's, it's something that's, yeah.
Sorry, I have a question. The main complaint, I understand, is the pain. But did the leg ulcers got better?
So the ulcers have improved,
Okay.
but they've never healed. And, with all this whole process, they just fluctuate. They go up, they go down. Sometimes they're a little bit better, sometimes they're a little bit more infected. But often he's in the community. And the main concern for him now is a lot of pain.
Were you able to put the compression stockings on?
Because I have a patient with arterial dystrophia. So you have to consider as a chronic pain syndrome on top of it, because a fairly small, how should I say, trauma can generate an arterial dystrophia. And he went through several interventions, so maybe you have to look also into some other.
And I totally agree with you. And we actually got our chronic pain team to have a look at him, and he's had a lumbar sympathectomy, but he's still getting recurrent pain now.
My question is, do you have any biopsy or opinion That the ulcers are vascular? Because
Yeah, so he has had a biopsy. There's no malignant transformation. They haven't found a dermatological cause for this. And really, we're stuck. And I think this is a problem that we're seeing with certain patients. You know, these are difficult patients to manage, and it isn't clear exactly what we would do next. And clearly, we don't want to amputate the patient, but this may be, as Lorenzo said, if you have really bad pain and you can't function, maybe the only option to do.
Salva?
I think treating these mixed venous ulcers, arterial-venous ulcers are complex. I think it's really individually based, very difficult to raise a flag based on the clinical findings that we are given. But I think it's important to know after the angioplasty, did the ABPI improve, or I think normally what I normally do is actually we scan ourselves with the scan, and sometimes the veins can be used for the bypass in case if you need a bypass. So whether to do the venous first or whether to do the arterial first, all depends. It's just complex things. I don't think we can really just say based on individual findings. But I think I want to know whether the ABPI has actually improved after the angioplasty.
I wouldn't say significantly. But to be honest, we tend, as a unit, to really focus on the duplex afterwards. You know, is there another target to go on rather than the ABPI? Maybe this is where tissue perfusion processes, toe perfusion may have a role. But I think actually understanding the perfusion to the tissues is still an unknown.
I think most of the ulcers are painful because of not because of the ischemic component. They may be painful because of the tissue loss itself. Some of them are excruciating pain, so sometimes they actually get better off with shaving the ulcer and putting some skin graft. I don't know whether Mark used to do that when I was in St. Thomas, right? So I think there are multiple reasons why people get these painful ulcers without any, even though they have a good blood supply. Thanks.
So, to be clear, you have treated the superficial veins, the ulcers got healed?
No.
Okay. Is there still any swelling of the extremity?
To be honest, the swelling was relatively minimal beforehand.
Yeah. Did you rule out any outflow obstruction of the venous system?
Well, it's a very good question. So we do that, and there was no outflow obstruction. And you know, in our algorithm, we'll talk about that as well.
Okay, so let's go on.
So we're still unsure what to do with that patient, and clearly you guys are as well. So we're going to take about another patient. This one's a winner. Well, I hope so. We have a 75-year-old male patient. He's got a mixed ulcer again, based on the ABPIs and looking at the picture. You can see here a venous duplex which shows superficial vein incompetence with a little bit of femoral vein and above knee popliteal vein incompetence as well. And he had a diagnostic angiogram, and this is his diagnostic angiogram. So as you can see here, it's a bit difficult to see because there's a lot of venous congestion, but essentially there is an occlusion of the TPT. So how do we manage that?
What's the runoff to the foot? So the dorsalis pedis, for example, is like giving...
Yeah, but the ulcers are all here.
Okay.
So...
And that's an important question, though, Lorenzo. So for you, if you have somebody who has an ulcer that's around the calf or around the gaiter region, how distally would you go?
I mean, you're right. I mean, I think you need to provide some outflow in order to give some flow. But I think, again, the wundosome theory you can apply to the arterial goes also with the venous. I mean, you need to get the blush in order to heal. You need to have, like, the good treatment for the venous part in order not to swell and not to create ulcers. So I think you can apply the wundosome of the forefoot to the calf. But, you know, I know that for any bypass, any revascularization, in my opinion, you need to give a little bit of outflow. You know, I think could be a good thing.
So the outflow keeps the revascularization open, but the actual delivery of oxygenated blood is from the more proximal, treating the more proximal
absolutely.
disease.
But if you start putting then compression bandages, you know, you want to have the best outflow possible. If not, you know, all the rest can go down, and the small collaterals are affected by this because these are small collaterals that are coming up to the surface. So if you start compressing, you don't have a good flow. I don't know, probably I have no experience really on large RCT to say that, but it's my gut feeling more.
Yeah, I mean, I think it's a difficult thing, but for this patient in particular, we decided that given this, we would go for the arterial system. So NT?
Yep, so treated this with recanalized into the perineal, angioplasty and drug-coated balloon. It's mostly soft plaque. We got a very nice angiographic result, really good flow into the calf, really good flow in the foot, some outflow for the revascularization. And then Patients on table, we're there. Why not? We treat the superficial reflux at the same time. So this is, if you have the patient with you, you want to minimize hospital visits, and you know that you have another target, that the risk to treating is very, very low, and the efficacy benefit is potentially quite high, why not do it at the same time?
Yeah, so who would actually do superficial venous treatment at the same sitting as the arterial revasc? Red for yes, and green for no.
Okay, many people said no.
Yeah.
Can I ask why no?
Well, it depends on how you're going to treat it. But during this intervention, you have to give heparin and perhaps some aspizole. So I wouldn't consider it. And if you make an operation of the great venous vein, and you also have a puncture site at the same position, could be a problem. I don't know how the wound would behave after putting a compression for, I don't know, 6 to 8 hours.
Well, I mean, I guess for the people who would do it, Salva, you had your. Do you have any comments on treating patients with anticoagulation and antiplatelets at the same time?
Another thing would be also you are in theater now, because you talk about theater time. You do the arterial, you move the patient, you do in ambulatory setting, you do the venous treatment. This could be another factor you can take in account.
I think whether to do both at the same time or not is what is practically possible, right? And how long will it take? And I probably would have done it at the same time. Giving heparin is probably, we do the endothermal ablation with warfarin on, we don't stop that most of the time. So that I'm not really bothered about it.
Agreed.
We have published papers as well about continuing anticoagulation during the procedure, because an endothermal ablation is hardly, you're not relying on the natural thrombosis side. We probably wouldn't do the multiple step avulsions, but endothermal ablation of this axial vein shouldn't be withheld. But I think I understand sometimes practically not possible for every unit, right? Sometimes maybe we have a different setting to do the endothermal ablation and different place in your suite.
I think there was a comment back there.
Wait, please, wait for the microphone. Microphone is coming. Then you need to tell us how the story ended. After this comment, you need to tell us. Because we are here like looking for answers.
Okay, one reason is that I like to mobilize my patients after I've foamed and then ablated the vein. And my radiologists want them to lie down for several hours before they can move. So for VTE prophylaxis reasons, I'll do them. As before, you probably end up doing both. You do the superficial veins first, because that's easier and more straightforward.
Yeah. Well, for us, we actually did the GSV at the same sitting. We put him in compression, and actually he's doing really well right now. So again, I think it's more about, as Lorenzo said, we don't understand the exact algorithm, but it's very patient dependent. But for me, if you do have arterial and venous disease, it's not something to not think that it can be done together. So how do you define success of your arterial treatment? Is it to allow compression alone? Is it to maintain arterial patency after the ulcers heal? Or do you need to keep on doing arterial work to make sure that you don't have recurrence of the ulcer?
So green flags if you just want to make it safe to compress. Yellow flag if you will keep intervening on the artery until the ulcer is fully healed. And a red flag if you'll keep intervening on arteries even after the ulcer's healed to try and stop it coming back.
I think they are more yellow than green. I was also a bit
slightly more yellow, so you keep going until ulcer heals.
But you need to see, in my opinion, it could be a balance. You need to see how much the arterial component is really affecting these patients. So I think it's a mix, like, for example, if you do an ABPI from 0.4 goes to 0.7 and 0.6, I would accept it. Maybe if they go back to 0.4, yes, I keep doing it.
But again, Lorenzo, it's very interesting. You use an ABPI as your as an output measure there, which when we were first of all talking about it, you know, it wasn't something that was actively encouraged by everybody. So maybe we need a better outcome measure in this group of patients other than ABPI, and I think toe pressures might
maybe
be.
This event will push us to think about a better outcome, because we all realize that it's not completely all right.
I actually want to ask a question. It's too loud to ask a question. Often we have been asked to, there are a lot of diabetic patients, they have a false ABPI, high ABPI, right? That they do have some tibial disease, but they have, in a patient with the leg ulcers, would you guys, so ABPI 1 or more than 1, But there are some tibial disease, but the patient has got no ulcer problem in the toe or the foot, it's a leg ulcer. I want to know how many people are happy to put a compression bandage with the tibial disease with an ABPI more than 1 because non-compressible calcified vessels.
I think that's a really interesting question.
This is where the TBI could help you, maybe.
Can help, but I think the thing is the leg ulcers, right? So leg ulcers and tibial disease, I don't know.
So I think to be honest with you, Salva, I find it quite difficult to put full compression in patients who've got arterial disease, and particularly if their ABPI is below 0.7, I certainly wouldn't do that. Between 0.8 and 1, possibly lower pressures, but I wouldn't be doing.
I think what Salva's saying is in the setting of an ABPI that's obviously not reliable.
So I don't mind allowing them trial of compression and see how it goes.
Yeah.
I want to know what the audience thinks. I think we can take a vote. If people are happy to give a compression with an ABPI more than 1, although there are some tibial disease on the arterial duplex scan, are you all happy to green if you're happy to give the compression stockings?
So if you're happy to give compression stockings with a falsely elevated ABPI, red flag.
You wouldn't.
No, if you're happy to give compression in a falsely elevated ABPI that you know is obviously abnormal, red flag. Few people would give compression. A lot of people, not sure. Green flag, you definitely won't.
They definitely do the duplex scan. You see, maybe you need to check. Some diabetic patients don't have any kind of tibial disease. But Jill.
I think in these situations, this is a really nice use for pedal acceleration time. We've started a study now doing a baseline PAT and then apply compression and then take the PAT again, because usually the toes are exposed. You can get a nice PAT right on the top of the foot. I think we have a lot to learn.
Yeah, and I think that's a very important point, trying to understand what would be the next thing. Now, for the sake of time, we're going to just briefly go through this last case, and I'm just going to take you through. So it's an 85-year-old lady. She's come in. She's got a mixed ulcer disease. NT's taken her to theatre. You can see all of these things. This was about 4.5 years ago. Tidied up the arterial disease, and we basically did okay. Her ulcer started to heal, but then she's come back with worsening ulcers. And this is her ulcer here, and it's pretty bad. So when do you start looking for deep venous disease?
So green flags if you never look for venous outflow obstruction because you don't think it affects the whole healing of mixed ulcers. Yellow flag if you do it early on as part of the initial workup because you think early treatment is useful. And red flag if you only do it once you've treated the arteries and the superficial veins, and only then if that doesn't work do you do it. Okay, so it's a pretty strong opinion that people look for deep venous outflow obstruction early on. That's
at least signs of the duplex, that shows, and then probably you can investigate more.
Well, I mean, for us, we tend to go for cross-sectional imaging. So this was her MRV, and as you work your way down, you'll start to see things. Remember, it's a right leg, and this is it. As you walk through. Very little in way of post-thrombotic disease, but did anyone spot anything that may be something to target or to look at or interrogate anymore? I'll go back to this one. Ooh.
So keep an eye on the right common iliac vein as it comes down.
Do you want to just...
So I had a feeling that there might be a compression there of the right common iliac vein between the artery and the spine.
So we basically now, knowing this, took her to theatre. We did a diagnostic venogram and intravascular ultrasound scan. I think something to mention, she had renal failure. We tried to minimize the contrast, but either way, the information that we got from the IVUS was quite important, and they've been highlighted here at the top and the bottom. That's a normal vein on the top.
And this is the point of maximal compression at the bottom here. So it's about 60-70% when you measure it on IVUS.
So who would stent on this? Recurrent ulcer,
green flag, yes, stenting, red flag, no stenting.
We've tackled the arterial side. So there's a 70% reduction.
Wait. Tito said never.
I mean, you see a compression, but how can you hemodynamically prove that this is a compression? No, only from the area of, the compressed area. It is very, very risky.
very risky. You've seen what her leg looks like on the last picture.
Absolutely, but it is a right-sided mitral. It is very difficult from a legal point of view to prove that this is a right-sided mitral. This is my point of view, just.
Yes, the same opinion. You have to make some hemodynamics.
Do you find hemodynamic assessment particularly useful in deep venous obstructive disease? Yeah, it's useless, isn't it? But her leg is on the borderline of being chopped off, right? So this goes back to, so I'd like to tie this back into the previous two talks about RCTs, yeah? RCTs don't give you an answer to a question. When you look at an odds ratio and a hazard ratio, what it tells you is if you did this experiment 100 times, 95 times it will give you this result. If a patient is on the borderline of losing their leg and there is a 5% chance that a relatively safe intervention might work, you will find it very difficult to find a patient who will tell you not to try it. Right? And this is something we have to bear in mind when we look at RCT evidence.
So we did opt for stenting, and it was mainly because we are actively looking for deep venous disease. And I totally get that this is an area of controversy, and I think that it needs a lot more work on it in terms of the specifics of the defining what a functional stenosis is. We don't have that information right now. We used IVUS. We put a stent in relatively straightforward. It's equivalent of a nivel lesion. One would expect this to be quite well done.
A Veneti stent.
Say again?
Looks like a Veneti stent.
It was.
Yeah,
it was indeed.
This was just before the Vici came off the market.
And we then did appropriate wound healing. And you can see here, this is 6 weeks later. And this is 3 months later. So we had a very good improvement on this, and everything's going well. 4 years later, she represents like this. And this is actually in January now, so a couple of weeks back. We then did some imaging, and this is the imaging here. You can see that we've got an occluded femoral vein, common femoral vein, and also the iliac vein stents have occluded. And we have some residual stenosis in the SFA, as well as the popliteal stenosis. So we did some cross-sectional imaging. Can anyone spot what might have happened here?
Migration of the stent.
Yeah, exactly. So I probably tried to be a bit too cute with the stenting first time, and I should have left it a little bit higher and oversized a little bit more. But over time, the stent has slipped just 2 centimeters distally, and now is not covering the compressive lesion anymore, and everything is occluded. And she come into hospital. She's now septic again from the leg ulcer, and she's got a new AKI on top of her chronic kidney disease also. So we have to do everything with CO2. We go through the stent, and you can see the stent is now occluded, but the femoral vein is still patent. And then we took down a penumbra, did a thrombectomy of the deep veins and of the stent, and re-angioplastied the stent and extended it more proximally to cover the compressive lesion again. So you can see the femoral veins now open after thrombectomy.
Fantastic imaging on CO2, by the way, because we don't see many times the CO2 used in venous. Do you often?
Not routinely. I mean, this is something.
It's pretty impressive. I mean, it's.
Yeah. So
does anyone use CO2 here in this room for venous? Something for next year. Thanks. Let's go on.
Okay, so look, we're going to conclude now, but because we're running out of time. But I want to take you through our algorithm, and this is work done by Steve Black who's back at the back there with Vanessa Livingston, who really developed what we have called the LUPA pathway, the leg ulcer treatment pathway, to try and improve access to patients to the hospital. And the first thing you need to do is obviously complete the leg ulcer assessment, understand what's wrong with the patient, make sure you understand whether there's a dermatological condition, whether there's nutritional problems, but perform an ABPI. And I think what we're trying to identify is if you've got arterial problem or not. If you have an arterial problem, then really that needs to come to hospital pretty quickly. But even if you have a venous problem, I would still argue that that needs to be treated as quickly as possible. When you get to hospital, that's really when the question comes. If your ABPI is pretty low, clearly we need to follow the arterial side, and I would suggest that an endovascular strategy is the best strategy to have in these patients, particularly when they have extensive ulcers. As Salva said, he might consider a bypass. In my hands, I'd really try and avoid that as much as possible. The question comes about when you have deep venous disease and how do you treat that? We are being very aggressive at the moment at trying to image it, and I think everybody in this room has already said that they will look for some form of cross-sectional imaging to detect it. But as has already been identified, we don't have perfect imaging, and that may lead to certainly some overtreatment. And I think, as has been said by Isaac, the truth is there are some very simple conditions that you can treat with some foam sclerotherapy, and we're very fortunate to have Lily Benton, who's looking at this in terms of trial way to understand with patients who have venous ulcers, if you put some foam sclerotherapy, can you actually improve their treatment without doing all of the clever things? And I think right now there is still a lot of uncertainty, but it's a massive area, Lorenzo, that we need to get on top of. Thank you very much.
Thank you so much. I think it was great, because it's a very controversial topic. We went through different solutions, different opinions. No one is right, no one is wrong, because there's so much still to know.